Welcome to my channel. This is the playlist of history taking, and in this lecture we will discuss the respiratory system specific history taking. First we will discuss the what is cough, sputum, hemoptysis, wheezing, stridor, dyspnea, shortness of breath, leg edema and chest pain. We will discuss all these in the respiratory system pathology. First is a cough. If patient has cough, we will ask him about onset and duration. If it's short, prolonged and paroxysmal. Paroxysmal mean if it occur at night. Short cough is usual in upper respiratory infection such as in common cold. Prolonged or paroxysmal coughing is characteristics of asthma or chronic bronchitis when there is inflammation of bronchi. Foreign body may be responsible for the abrupt onset of paroxysmal cough, especially in the children. In the cough, we will also ask the character. Is it dry or productive? If it is productive, we ask about the sputum color, volume, painful or painless, harsh or barking or painful cough, which suggests laryngeal inflammation of larynx. Does it occur in bouts, suggestive of whooping cough? If it's occur in bouts, then suggestion of whooping cough. And the third thing in the cough, we will ask the timing. Daytime, is it in the night time, early morning? If nocturnal, causing sleep disturbance associated with the wheeze, suppressive of bronchial asthma, or due to the secretion running down the larynx from the posterior nerves in the patient with chronic infection of the nose or sinuses, or due to gastroesophageal reflux. In the patient of chronic obstructive pulmonary disease, patient sleep well but has cough, dyspnea and wheeze which become worse on rising in the morning and goes to the bed at night. These are the specific things in the specific diseases. And the fourth one, in the cough, we asked about the relieving factor, if there is any drug which relieve the coughing stimulation. And fifth thing is the aggravating factors. We will ask from the patient cold, dust or any pollen, any perfume, certain position can aggravate the pain. Angiotensin converting enzyme inhibitor. These are the things we will ask occur during or immediately after swelling of the liquid, which suggests neuromuscular disorder of the pharyngeal muscles, occur during work week days with wheeze and dyspnea, which is relieved by the weekend or during holidays. We also asked about associated symptoms, sputum, if there is any sputum with the cough, hemoptysis, nasal discharge, fever, wheezing, stridor, leg edema, cyanosis mean bluish coloration of the skin, night sweating, weight loss, all the things we will ask as associated symptoms. Next we asked about the severity. If the origin is pharynx, common cause is the post-nasal drip. Clinical feature is the chronic rhinitis. If the origin is the larynx, common causing laryngitis, tumor, whooping cough, and the clinical feature is larynx is a voice box, and the its clinical feature are the voice or swelling altered. These are the harsh or painful cough. These are its clinical symptoms. If the origin is the trachea, common cause is tracheitis, inflammation of the trachea, and the clinical feature is the raw retrosternal pain with cough. If the origin is the bronchi, common cause is COPD, asthma, bronchial carcinoma, And the clinical features is the dry or productive cough, worse in morning, usually dry, worse at night if there is asthma. And the bronchial carcinoma, it's persistent. These are the things you need to remember. Lungs parenchyma, common causes is TB, tuberculosis, pneumonia, bronchiectasis, pulmonary edema, intestinal fibrosis, and these are its clinical features. Often with the productive if there is tuberculosis, dry if there is pneumonia, productive become later it become productive, first dry. Bronchiectasis, it's productive. Pulmonary edema often at night. And the intestinal fibrosis, it is dry and irritant. Next thing is sputum, asked about the amount if there is small or large amount of purulent sputum influenced by the posture for several years is the suggestive of bronchiectasis. Sudden production of large volume of purulent sputum on a single occasion suggests a lung abscess or emphysema. Large volume of watery sputum with a pink tint in an acute breathlessness patient suggests pulmonary edema. Asked about the color, mucoid clear gray, white in the chronic bronchitis and asthma, mucoid in case of asthma and chronic bronchitis. Thick viscid sputum which sometimes take the shape of bronchial cast occur in asthma, especially the kind of associated with pulmonary bronchopulmonary aspergillosis. Purulent yellow or green in case of infection, bronchiectasis or abscess. And the note, yellow sputum might occur in asthma without bronchopulmonary infection due to the excess of esophagitis, rusty in the case of pneumonia. Serous, we also asked about serous. It is clear, watery, frothy in alveolar cell carcinoma and acute pulmonary edema. There is a serous formation. And fourth, we ask the patient about the sputum is the smell in abscess and bronchiectasis. Sputum has sometimes have offensive smell due to the infection. Taste, contain blood or not, mixed or pure blood. Variation with the position in case of bronchiectasis, it is vary with the position. Associated symptom, if there is any dyspnea with the sputum, fever, weight loss or the night sweat. These are the serous, mucoid, purulent and rusky. You can see here, these are their appearance, you can note down, and these are their causes. Next we have an example. These are the diagnosis. This diagnosis is the acute cholera complicated by the pneumonia. This you can read here, and these symptoms are the diagnosis of these. And the example number 2, this is the diagnosis of post primary tuberculosis. This you can read. And the example number 3, this is the diagnosis of bronchiectasis, damage of the bronchi. And this is the example diagnosis of pulmonary fibrosis. And the next we have a hemoptysis. In the hemoptysis in ask the patient about is it true hemoptysis, hematemesis or epistasis. Epistasis means bleeding from the nose, and it is the blood from coughing. Its amount small, large or massive. Its nature frothy pink. Sputum, streaks of blood or the clear blood. Duration, associated symptoms with this with large amount of purulent sputum over several years indicate bronchiectasis, pink, frothy and associated with the acute dyspnea in case of pulmonary edema. These are very important points. With sudden onset of dyspnea and pleuritic pain in case of pulmonary infarction, with purulent sputum and the fever in case of pneumonia, and the night sweat weight loss and fever is the sign of TB or a lung cancer. TB, lung cancer, lung cavities contain myxedema and bronchiectasis. Hematemesis can be massive. Anti-flank massive hematemesis is defined as more than 500 milliliters of blood in 24 hours. Okay, because blood originating from nasopharyngeal or the gastrointestinal tract can mimic the blood coming from the lower respiratory tract, so it is important to determine initially that the blood is not coming from one of these alternative sites. Clues that the blood is originating from the GI tract, including a dark red appearance and acidic, in contrast to the typical bright red appearance and alkaline pH of true hematemesis. This is the indication. Causes of hematemesis you can see here. If there is bronchial disease, these are the causes. If there is parenchymal disease, these are the causes. If there is lung vascular disease, causes are here. Cardiovascular disease and the blood disorder, these are the causes of hematemesis. These are the examples. Diagnosis is the common cold complicated by acute bronchitis, inflammation of the bronchia. Example number 2 is the diagnosis of bronchial carcinoma. Next, we have wheezing. In the wheezing, we ask the patient about the onset and duration, if it is episodic or continuous, spontaneous or induced by exercise in case of bronchial asthma, by drug also in case of bronchial asthma, and occur in occupational in case of bronchial asthma or occupational lung disease. We can ask about the timing in night bronchial asthma or after waking in the morning in case of COPD. Remember this question. In question number 4, we can ask the associated symptom of respiratory system. We can discuss previously. All this we can ask. And the next thing we ask from the patient is the stridor. If there is stridor in the breathing, we ask the patient about sudden or gradual, its duration. If the stridor exertional, biphasic or continuous, its timing, relieving and aggravating factors, severity. If this is fair, then there is cyanosis. Associated symptoms, you know, that is the fever, cough, choking, runny nose, sore throat. If epiglottis involved, then there is high fever, dysphagia, rolling, toxic. These are the questions we can ask. Differential diagnosis of the stridor is the foreign body impacted in the upper respiratory tract, in larynx about the level of the at the level of the vocal cords, angioedema, inflammatory lesions, croup, epiglottis, and the diphtheria. These are the differential diagnoses of stridor. Pharyngeal or retropharyngeal abscess, congenital lesion like vascular rings, stenosis, tubers, papillomas, etc. Pressure due to the thyroid enlargement. These are occurring in case of stridor. And in this lecture, we will discuss the respiratory system history taking and their differential diagnosis. I definitely sure that you like this video, and next we will discuss the further system step by step. Thank you.